Hi and welcome. I'm Chris Goslin. I'm a registered nurse and I'm pursuing a bachelor degree of nursing at U of M Flint. I work in the emergency room in Grayling Mercy and I had the opportunity to work in another rural hospital. I also hold several certifications that are required by our department. Back in the beginning of our semester, we talked about what motivates us, and over 3/4 of us said family. How many of us have had elderly parents or grandparents with chronic illnesses or who were in nursing homes? We'd do anything to help them, wouldn't we? We'd help them be more comfortable, live as long as possible. But at what physical cost are they or you willing to pay? This isn't a conversation about euthanasia. It's a conversation about CPR and what you'd want for yourself and your family. It's about finding out what's right for the patient and who should decide. In America, there's something called presumed consent, that unless someone specifically documented they do not want resuscitation, DNR, that the medical professionals will do everything they can. Does that make sense for every person? That depends. Let's see what's involved. With basic life support, most people are most familiar with this. It's chest compressions, and you perform that at 100 compressions per minute. There should be full recoil between the compressions or the rising of the chest. So going at 100 beats per minute is pretty darn fast. And you're familiar with this mostly from TV because people get up and walk away from the situation. And if it's on TV, it must be real, right? Advanced cardiac life support, or ACLS, involves much more. It's typically done by the EMS people or in hospital settings. Beyond the compressions, it involves stripping the patient down to put shock pads on their chest and back, if that wasn't already done. Create an artificial airway with a tube going down their throat, putting in 2 or 3 big IVs or a central line, which is a needle or needles, into the biggest veins they can find. And, depending on the situation, a urinary catheter. Medications are also used to bring a heartbeat back to a normal beat. And if the patient is stabilized during this process, and remember they're probably unconscious because we have a tube down their throat, then another tube is inserted into their stomach so they won't throw up those contents. Most family members want anything and everything done to save their loved one. In American medicine, any invasive procedure requires a signed consent unless it comes to CPR. There's what they call presumed consent, unless the patient is wearing a DNR bracelet or if there's an order on the chart. This obligates us to perform ACLS on any dying person without regard to what their wishes are or what their family's wishes are. The history of CPR began in the 1960s when it was used for healthy people who suffered an acute insult, something like drowning, electrocution, dying during surgery. CPR is something that will restore a normal heartbeat, but it won't prevent the dying process. It only prolongs it. So why don't more people choose to be a DNR patient? I hear older people say all the time, I don't want a bunch of tubes stuck in me, keeping me alive. Many people don't have the conversation with family or document it with their health professionals until they're too sick to choose. And even if they can choose, they may be distracted by pain or depression and not be able to think about it. Different religions also have different customs. Islamic people believe only the same sex can touch a patient. Hindus believe only their family members can touch them. Buddhists want consciousness at the time of death. Some people who think they've chosen have documents that say don't do any extraordinary measures. Well, what is that? No tubes? Do you stop at 5 minutes? If it didn't work, tough luck? One woman's directive even said she would take CPR, and in the event we brought her back, she didn't want a respirator. Well, what if she wasn't breathing yet? Does someone just stand next to her for an indefinite time with that mask on her face providing breaths? Talk about the high cost of health care. Real statistics are that success rates have not changed in 30 years of ACLS. If they have VFib or VTAC, success rates are 22 to 30 that the person will survive discharge from the hospital. Anything else, including a flat line, the chances are 0 to 7.5% that they will survive CPR. We don't know how long a lot of patients were without oxygen, and we don't know if they had compressions that circulated enough blood to their brain or other vital organs. There's sometimes often unintended consequences too, like broken ribs, a central line that can bleed internally or puncture a lung. Medications make a heart look like it's working, and that gives false hope to the family if they happen to be in the room at the same time. I'll never forget, as a student at McLaren's ER, we had a full arrest come in by ambulance. She was about an 80-pound-year-old scrawny woman, and the staff thought it would be good practice for the students to do CPR. As soon as I started, I could feel her breastbone broken away from all her ribs. It was a horrible feeling. While we were trying to revive her, EMS said they had gotten her out of the nursing home as fast as possible because the family was hysterical. Turns out this woman had suffered with cancer for over 5 years, had a morphine pump in her belly, and was a DNR hospice patient. She was simply trying to die, and that was her family's way of mourning. And now she had broken ribs and a tube down her throat with a bunch of drugs making her heart look like it wanted to beat. It was horrible and traumatic for the family and the students. And no, she didn't survive. In the beginning of my research, I fully expected to say that the doctor is the best one to decide who's a good candidate and who's not for life support, advanced life support. In other countries, presumed consent doesn't exist. In Britain and Japan, doctors write DNR orders regardless of what the patient or their family want. Many families cannot get beyond the obligation to do everything possible as far as them making a decision. They try to prove their loved one's worth to the family, and they can't say no. Without your preference documented, you'll automatically get ACLS. It's all or nothing. JCO, the Joint Commission of Accreditation of Healthcare Organizations, requires that CPR be administered on any dying person who is not requested otherwise in a hospital setting. I think this lady wanted us to know how she feels about it. In American healthcare, patients are expected to determine what's best for themselves. How can they do that? They don't know as much as a doctor, unless they are one themselves. Ethically, interventions are considered futile, with a less than 10% chance of working, and they should be withheld. That's 1 in 10 chances. Who's willing to gamble with those odds? Some physicians feel heroic efforts signify their commitment to the family and to life. And our cultural norm is the rule of rescue. It's part of our human nature to save people if we can, and extreme efforts are often interpreted as someone who is extremely worth more effort. So it might sound like I'm against ACLS for saving lives, but obviously I'm not. I work in an emergency room, and I work to promote life extension in acute or urgent situations. When it comes to your grandmother or your father in a life or death situation, do you really want their last days to be spent in a way they'd not wish? Do you even know what they wish? I'm against one order for determining the end of life care, which is typically just a do not resuscitate order. I believe there should be one form for determining personal preferences, simple, free, no complicated language. I think the form should be required as part of a medical record and talked about with your doctor and your family on an annual basis. God knows they require 100 other forms. What's one more? Now, this is not a legal form by any stretch of the imagination, but it is a conversation starter. And even if just a few of you took it to your family, your grandparents, your parents, your siblings, and had the conversation about their wishes and your own wishes in the event of a medical emergency, if nothing else, that would be that many more people who could speak on behalf of their family if the situation ever arose. So why does an end-of-life conversation matter? Medical emergencies happen suddenly, and the medical community is going to do what they know, unless you tell them otherwise. What would you do on behalf of your family? Do you want to be responsible for a decision that causes more pain or complications if it's unlikely they're going to survive? We just want the best for our families. Let's make sure we know what that is. Thank you.